So next is Stoma Complications. A 40-year-old gentleman underwent a lap septal for symptomatic UC, which failed with medical treatment 5 days after surgery. His vital signs are fine and clinically well. However, stoma output has been more than 2 liters for 24 hours for the last 2 days. Please take me through your management plan. So this is a high output stoma, and this can cause water, sodium, magnesium depletion with the malnutrition as a late complication. The management is to identify and treat the underlying cause, and some causes of high-output stoma are short segment of the residual small bowel, intermittent bowel obstruction, intra-abdominal sepsis, and medication like sudden withdrawal of steroids on metoclopramide and enteritis. Other and supportive measures include the intravenous fluid and replacement of electrolytes, oral hypotonic fluid restriction, less than 500 ml, and use of oral glucose electrolyte solution like Senma solution, WHO solution, and diorolite, antidiarrheal medication, loperamide, anti-secretory medication, omeprazole, nutritional support, wound care, and psychological support. This gentleman recovered well and was discharged. He has no issues with the rectal stump and is not keen on ileoanal pouch or proctectomy after careful consideration. You saw him 18 months after surgery and he has developed peristomal hernia and is keen for further management. How common is peristomal hernia? So it's very common. Lifetime 50%, 2 years 40%, and 1 year 30%. After discussion, surgery is proposed as he is young, active, and peristomal hernia has been symptomatic. Is there a better method of repair than others? So suture repair is a suture with a very, very high recurrence rate and therefore not recommended. Mesh repair is appropriate in the elective setting, though there is no evidence to suggest which approach is best, laparoscopic versus open. And if laparoscopic approach is preferred, mesh without a hole is suggested in preference to a keyhole according to the European Hernia Society. And nowadays, if it's a recurrent or high risk patient, a sugar bracket technique can be done, in which bowel wall is lateralized and a flap valve mechanism is created with the mesh, which can tolerate the raised intra-abdominal pressure. And if they do laparoscopic, they do the intraperitoneal only mesh called IPOM. Thank you.